okay, parents, your kids are going to turn out just fine.
This episode of the podcast is brought to you by FOCO. That's FOCO, F-O-C-O. If you are a parent of a child or teen with ADHD, you know how challenging it can be to keep them focused and engaged. FOCO is the all-natural solution for ADHD, whether it's for school, homework, or just everyday activities. FOCO helps your child or teen stay calm and attentive. Before trying prescription drugs like Adderall that can come with harsh side effects, I recommend you try FOCO. Visit ThinkFOCO, that's ThinkFoco, thinkfoco.com for more information. This is the Your Kids Will Be Fine podcast. As always, I am Dr. Michael Milobsky, board-certified pediatrician and father of 7. On Your Kids Will Be Fine, we're trying to help filter the information overload for parents so you can make healthy decisions for your kids, not feel overwhelmed by the anxiety of your choices, and to know that your kids will be fine. Today, we are going to talk about the top 6 ways that parents at home can do, things that parents can do to keep your child out of the pediatric emergency department. Having to drag your child to the PDZR in the middle of the night because you are unsure and anxious and worried is probably one of the more unpleasant experiences, especially if it's winter and especially if it's overcrowded and full of really sick kids. And there's 2 main reasons why most parents, for non-emergent things, obviously we're going to exclude life-threatening situations, but for non-emergent things, why you end up there. And it's mostly, one, you don't have enough information about the situation you're facing. And 2, competent and balanced answers to your questions are just not available at the time that you need them. If your practice is anything like mine, our pediatricians and providers are already pretty overworked, and most calls overnight are answered by a nurse call center. Those nurses use an algorithm on the screen that is very slanted towards sending you in versus working through the question and giving you tools at home. So we're going to talk about the top 6 things that you can do for common issues that tend to end up in the pediatric ER, but often don't need to be there. From this discussion, we are excluding certain things that all parents should be doing every day for injury prevention and emergency prevention. Those are, of course, child-proofing your home. Keeping your kids away from dangerous things is the number one way to prevent ending up in the ER because of them. Supervision, obviously proper supervision of your kids, especially around dangerous situations or issues where they could get a hold of things that they shouldn't. 3, water safety. That's a very specific and separate topic that requires a lot more attention and supervision. And car seat safety. All of these things, when you pay attention to them every day, will definitely keep you out of the ER more. But we're going to talk about 6 specific situations that you can use and get tools at home to help you know when you don't need to be there and when you do. Let's talk first about fever. Fever is probably one of the most common reasons why people end up in the pediatric ER and are very frustrated when they get a fast exam by an experienced pediatric ER physician who can tell by looking at your child that they are fine, give you some fever medicine and send you home. And you think to yourself, yeah, I could have done that myself, but I just didn't know. When to go in and have to be seen is very age dependent. So children who are between 0 and 1 month of age, when they have a fever of 100.4 or higher, and that is from a rectal temperature, please, when you have a baby at home, especially a young infant, get comfortable and good at taking a rectal temperature. Temperatures in the ear and temperatures on the arm are simply not reliable enough. A rectal temperature is really the only way we can offer any sound advice. But if you are a child under a month of age or younger, you will need to be seen if you have a fever of 100.4 or higher. It is simply because they're at much higher risk for more severe infections and they don't show as many signs or symptoms and they're harder to interpret. So all those children need to be seen. The children between 1 and 3 months also generally need to be seen. But there can be a little more leeway about appearance, but still they are at higher risk enough because they are more vulnerable to infection. Over 3 months is generally considered where a well-appearing child who has a documented fever but looks good, and you can have a conversation with a pediatrician, usually someone in the, whether it's your call center or your actual doctor, but most of those kids, if they are not having trouble breathing, they are able to tolerate fluids, and they are alert and interacting with you normally, can often wait until the next office day. So knowing these things can often prevent a lot of unnecessary trips. 2, ear pain. The biggest concern about ear pain in the middle of the night is that my child has an ear infection that needs to be treated right now. And the truth is the vast majority of ear infections are viral. Most ear infections, unfortunately, regardless of how they look, do not need antibiotics. And ear pain in a healthy child who happens to be fully vaccinated is not an emergency. Sometimes the pain is if you don't know what to do. So for my patients, I tell them to use a weight-adjusted dose of ibuprofen. So following the directions on the box only by age, unfortunately, will often underdose your child, and you won't get optimal pain control. So knowing what that is with regular contact with a pediatric office based on weight is important. So using ibuprofen in my experience is way better for the pain symptoms. And 2, using a simple inert oily drop that goes in the ear can block air getting to the eardrum and can alleviate a significant amount of pain. And doing those 2 things can often be the difference between being able to feel like you're managing this at home appropriately or feeling like you have to go in. So knowing it's not an emergency and knowing how to manage the pain. Number 3 is vomiting. Your child wakes up and is throwing up over and over and over. And they were just fine yesterday. And that is often a reason why people end up in the ER. And you go, they look at your child for a few minutes. They give your child a little pill that dissolves in their mouth. The vomiting stops. They have a popsicle and you leave. And you wonder, why couldn't I have done this at home? And the truth is that you can. Vast majority of vomiting is viral. And if you have the tools to at least start to manage it at home, very rarely will you need to go to the ER just for vomiting. The medicine is called Zofran. The generic for it is ondansetron. It is something that if every one of my families that has little kids, if they ask, I offer it to them. It's a really good idea to just keep this in your house, especially if you have kids at daycare. If they are throwing up in the middle of the night, it is a thing that you can do at home before going to the ER is properly dosing them with the medicine at home, seeing how they respond, offering them fluids. And if they feel better, look better, tolerating fluids, you have completely canceled any reason to go in to the emergency room in the middle of the night and can follow up with your primary care physician at the next office day. So asking your pediatrician and getting a prescription for Zofran can mean the difference between having to go in or not, often at an inopportune time. Number 4, head injuries. There is a set of criteria that all pediatric emergency providers generally follow. They are called PECARN, the Pediatric Emergency Care Advanced Research Network, the PECARN criteria. This is not information that's hard to find. It is easily searched on the internet. And PECARN has what we call very low risk, moderate risk, and high risk criteria. Parents should at least be familiar with what the very low risk criteria are if your child happens to hit their head. And knowing that is important because the very low risk criteria, if they're all met, your child almost never needs to go in and be seen. It's always a good idea to speak to your doctor's office about it, but it can really empower parents to feel much more in control of a minor head injury situation. So what are the very low risk criteria according to PECARN? So the first is that the mechanism should be low risk. So the mechanism being low risk is that the child had a fall that was less than 3 feet. The child is alert and interacting at their baseline that the parent is used to seeing. The child is not vomiting and tolerating fluids and is alert and didn't lose consciousness. And last, doesn't have any areas on the skull that feel swollen or soft. That does not include the forehead. A goose egg on the forehead in a well-appearing child is not considered significant and doesn't need immediate medical attention. So if your child meets all of those very low risk criteria, it is highly unlikely that your child needs to be seen. and you can observe your child at home for changes. And it's, once again, accessing your pediatrician's after hours service is always a fine idea, but knowing this can really mean the difference between the anxiety of feeling like you have to go in or not. So very low risk head injury criteria, according to PECARN, is information parents should have. Number 5, nursemaid's elbow. Here's the situation that you run into. You have a young child, usually under 5. You're playing with your child and holding their wrist and swinging them, or they're running away from you and you grab their wrist and pull their arm, and your child immediately seems to be in pain and is holding their arm and not using their arm because it's held against them and flexed. If that is the mechanism and there was no other injury, that is what we refer to as a nursemaid's elbow. People often rush to the ER to be seen. An emergency physician takes one look at you and listens to the story, does a brief maneuver with your baby's arm. They start using it in a few minutes and you go home and you wonder, I could have tried that at home and spared myself a trip, and that is true. There are 2 maneuvers. There's called supination and pronation. There are abundant YouTube videos, and there was a detailed video on my social media feeds on TikTok and Instagram about doing this at home. But if that was the only mechanism, it is completely appropriate to try this at home. And if your child begins using their arm and is much better within a few minutes, usually 5 to 10, then there's no reason to go to the ER and you've saved yourself a trip. So the maneuver that I recommend if you're going to do one maneuver at home is pronation, where you hold your child's arm and turn their hand over and over rotate it. You'll feel the pop of the ligament reducing here in the elbow, and then leave them alone. And they usually should be back to using their arm in a few minutes. If they are not back to normal within at least 20 minutes after the maneuver, and they seem to be in pain, then of course, hey, you got to go in. But most of the time, this can be done at home first. And the last thing to prevent parents unnecessarily from going to the pediatric ER is understanding a water submersion event. The story usually goes, you are supervising your young child at the pool. They briefly go underwater and you pull them up. After a few seconds, there's some coughing and sputtering, and you bring them to the side. The problem that we're running into is that there is an enormous amount of social media hysteria over the concept of dry drowning, that your child might have somehow, because of this brief submersion, develop over the next few hours an invisible dysfunction of their lungs that can be silent and will kill your child in their sleep. And that is simply not a thing. Of course, if your child is not normal, or if it was a more significant or prolonged event, you seek care at the scene and you go directly to the hospital. But that is not the most common scenario. The most common scenario is that the child is pulled to the surface quickly. That child should be set aside and someone should sit with them and watch them. They might have a bit of cough, but if over the 2 or 3 hours after the event that you can watch them, their breathing seems normal, not rapid, elevated, or labored. Their coughing is not persistent or getting worse, and they are comfortable and alert. You can be assured that there is no concern for a aspiration event that would cause them harm, and you don't need to go to be evaluated. If your child has a submersion event that could be longer and more significant, and your child is persistently coughing or having respiratory changes, then you know, hey, I've got to go into the ER and be observed and be watched, possibly monitored, possibly get an x-ray. But dry drowning, as it's described online, is simply not a medical reality and not really something that parents need to be ultra concerned about. Having this information is the difference between staying home and feeling like you have to go. So I hope this was helpful. And as always, you can find our podcast at yourkidswillbefine.com, also our YouTube channel. You can leave comments. You can download all the episodes. And if you're interested in working with me privately, I do have a concierge service, Chicken Soup Concierge Pediatric Care, chickensoupdenver.com, although the website is under construction. You can call or text directly at 720-530-5109, and we'd love to work with you. So give us a call and join us for our next podcast. We have some interesting podcasts coming up in October. with some very special guests, and I'll be joining the What Fresh Hell podcast as well. So stay tuned for those.